Thank you so much for being here. We're going to go ahead and get started. Um, Tonight, as you know, we are going to discuss compensation trends that we're seeing in pediatric contracts and tips for negotiating your contract. So, we're going to start out just addressing why this matters, why this is a topic that we think is worthwhile and something that um, you should you should pursue and something that, again, is a topic that is worth discussing. Um, More than half of doctors in the United States report that they experience professional burnout at some point in their careers. When those doctors are asked why, they cite lack of autonomy and the unrealistic expectations and burdens put on them by their um, employers and by the administration. We can't avoid all of that when we are um, hiring and when we are going to work, obviously. But through the contract review process, we can address a lot of it. We can hopefully negotiate around a lot of it. We can address the underlying problems and the places where we can't completely eliminate it. We can prepare for it. We can hopefully mitigate the effects. So, this is something that not only matters in terms of your compensation and in terms of your day to day, but ultimately really matters in terms of your overall well being and happiness. So, why Panacea? Who are we? Panacea Legal is a law firm that specializes in doctor employment contract review. We offer in-house servicing. We're going to talk to you about your contract. We're going to talk about the legal implications of what you're signing. We're going to talk about um, how your contract compares in the market. So, looking at what we're seeing versus how it compares with what we've seen in other contracts. And we're also going to offer all of that with 1 year follow-ups, meaning you can come back to us, ask any additional questions, and that is all offered with transparent flat costs. So you're not going to get a bill where we have billed our time for every email we've sent and every phone call we've chatted with you on. I am a licensed attorney. I have reviewed more than 2,000 doctor contracts in my career across all specialties, all practice types. My goal is always to help a doctor make his or her best decision. I want you to make the decision that is right for your career, for your goals, for your life. Sometimes that means walking away from a job, but if that is the thing that's going to get you closer to where you want to be, then that's the right decision. So tonight we're going to talk about the basics that should be in your contract, what to look for, what to expect. We're going to talk about how to ask questions about your contract, the questions you should ask, and how to approach them. And then we're going to identify red flags. Those are always the questions that I get. Those are always the questions that people want to know. What are the red flags? So we're going to talk through how to spot those when you're looking through your own contract. So when we're looking at the basic components, we'll then pull out those components that are most likely to be problem areas. And then again, those areas that potentially could be red flags. We'll start with basic contract components, those areas that are in most contracts and what we want to see in them. So these are the sections that should be addressed in contracts. Contracts are going to vary in form, in length. They're all going to look a little bit different. So you may have some that are 3, 4, 5 pages, and some may be 40 pages. And the reality is, they all could be okay. Anything within that range could be fine, or anything within that range could not be, right? The 40-page contract could be lacking in some of the details that we want. But these are the things that you really want to see. You really hope that these things are addressed in that agreement. So We first of all want to understand the term. Um, how long is the contract? When does it start? When does it end? Does it renew automatically? Do you have to do something on your part to initiate contract renewal? How do you get out of the contract? What's that process like? Um, we want to be sure that all of those things are addressed. We also want to understand the details of the actual job. And I know that that sounds overly simplistic, but understanding um, where are you going to work? When are you expected to be there? Are you full time? If you're full time, what does that mean? And I know that that sounds a bit silly, but is full time 40 hours? Are all 40 of those patient facing? Are there any admin carve outs? How can those 40 hours be divided up? Are there call requirements? Are those call requirements included within the 40? If not, how many extra call hours are we expected to work? All of those things are really relevant to understanding what's expected of you. We also want to know if there are additional responsibilities, teaching, supervision, maybe you're serving an equality role. All of those things are questions that should be answered in your contract. Of course, we also want the compensation. That goes without saying. We want to know what you'll be paid. We want to know what that pay will be based on. We want to understand the bonus opportunities. Can you make more based on certain metrics? Are there recruitment incentives? Are they offering a signing bonus or a stipend based on, certain things? Can you get money for relocation, money for student loans, things like that? We want to know about benefits. We want to understand what type of benefits they offer. Usually, you're going to see language in a contract that says something like the physician will be offered benefits that are um, the same as similarly situated employees. And what that means is you'll get the same benefits that everybody else has. And on its face, we look at that and think, yeah, that seems pretty good, right? Everybody's going to get the same benefits, and that seems fair. And when you're going to work for, let's say, a large hospital or an academic institution, I think that is fair. Usually, those kinds of facilities, those kinds of employers are going to have a pretty robust um, benefits offering. So I'm not particularly worried that you're going to have significant cuts to benefits. Maybe they're going to make some changes here or there, but they're probably not going to say, hey, there's no retirement plan. Um, the smaller the employer gets, the more concerning this can be. I reviewed a contract not too long ago. The doctor was going to work for a small private practice, and the language said exactly that. And so we um, said, okay, this sounds great. But then we decided, you know what, let's get a little bit more information here. And the doctor went back and asked, okay, I'm going to get the same as everyone else. What does everyone else get? And the answer was everyone else gets nothing. There were no benefits offered. So based on the contract, um, it looked good. Doing a little bit more digging, it wasn't great. So we want to be sure that the terms of the contract are reasonable, but then we also want to be sure that the terms of the contract reflect reality. We want to know, assuming there are benefits, when those start. Sometimes the benefits don't start for certain periods of time. So we just want that all to be really clear. We want to understand if there's PTO, CME support, all of those things. And then similarly, we want to know who's paying for malpractice insurance and if that's also going to cover tail insurance. Those things are significant. Those things can be significant costs. We typically do see that employers pay for at least malpractice. For those of you who may be new, who may be coming out of training and not familiar with what I mean when I say tail coverage, that is the malpractice insurance that's going to um, cover the work you've done after you leave. So a patient's going to have a certain amount of time to bring a lawsuit, and the tail coverage is going to cover that work. In Peds and in OB, that can be a substantial cost. So ideally, we do want the employer to cover it. But at the very least, we want the contract to tell us for sure who's going to pay for it. Indemnification is a clause that essentially says, hey, you won't be responsible for my actions, and I am not going to be responsible for yours. And that's in any type of agreement. And on its face, it seems pretty reasonable. But you start kind of digging into that a little bit further, and you think, okay, well, um, if a malpractice suit is filed against you, and the malpractice claim is based on something that you did, and the hospital or the clinic or the practice is made a party, they're also included in that lawsuit. And there's a clause in your contract that says you will indemnify them. That means that any liability that they have, you're going to be financially responsible. Um, that's obviously concerning because when two entities, and here I mean you and the employer, are working together, it's hard to separate out actions, right? So maybe you did something, let's say that it was a valid claim. Maybe you did something wrong, but maybe they had poorly trained a staff member, or they didn't have the equipment that they should have had, or right. I mean, any number of things that everybody kind of has a part in it. So what I like to see is an indemnification clause that's much more narrow. I like to see a clause that says that you, the doctor, will indemnify them, meaning you're not going to hold them responsible if you falsely bill. You violate the False Claims Act. If you do something criminal, if you neglect your responsibilities, if you do something intentionally wrong, right? If you are a bad actor, yeah, that's on you. If you discriminate against someone and you get sued, of course, you should be responsible. But if it's a situation where you do something that's a mistake, or it's an error that is a reasonable error, is something that maybe a mistake that anyone could have made. I don't think that you should have to also accept any liability that they would have. So that's what indemnification is. It's one of those issues that is difficult for a first year law student to understand. So certainly don't take my sort of 3-minute um, overview as um, the entirety of the subject, but just kind of a quick overview. You also, around liability, want to understand any financial penalties. There are contracts that say, if you violate the non-compete, you have to pay this much money, or if you terminate during the first 2 years, you pay X, or something like that. You want to know what that looks like. Those things need to be laid out. And then the last section that I think is worth kind of acknowledging here is that um, restrictive covenant. And this is something that, of course, gets a lot of attention. And we're going to talk kind of about the less well-known first. So the exclusivity covenant is something that applies during the life of the contract or during your employment. And it's going to say, hey, while you're working here, you can't work for someone else, or you can't compete with us, or you need our permission to work for someone else, or something along those lines. Um, Even in states where non-competes are not allowed, they're typically going to allow an exclusivity agreement. So essentially, this is a moonlighting restriction. Sometimes it's going to say you can't provide medical services, and sometimes it may say you can't you can't perform any work related to the practice of medicine. So that could mean teaching, that could mean writing articles, that could mean consulting. So you want to know exactly what is being restricted, and you want to know what, if anything, you can do to get that approved. Um, so that's kind of the first one here, of course. The next one is a non-solicitation. And um, that is going to be a section that says when the contract ends or during the life of the contract as well, you can't try to get people to leave their relationship with your employer. So you can't say, hey, these people are the worst. Don't work here. Let's go work somewhere else, right? Essentially, you can't poach. You can't try to get the employees to go somewhere else. You can't say, hey, when it's time for your follow-up appointment, don't forget, I'm going to be at this other place. You can't try to get referral sources. Sometimes they're specifically mentioned. You can't try to get people to leave and go somewhere else. And then non-competes, of course, are the ones that everyone sort of knows about. They're going to have those two components, geographic and time. So during the contract and for a year after, you won't work within 10 miles of the clinic. Now, they can be much more convoluted. It can say you won't work within 10 miles of any location where you build at least, you know, 100 hours over the course of a year. And you then have to sort of do that math, um, which would also mean it could potentially be multiple locations. I love to get it down to at least one location. Um, Also, of course, we want that to be as narrow uh, of mileage as possible. Um, you may have heard, that these went away or there was talk of these going away. That was pursued at the federal level under the previous administration. That sort of fell by the wayside. Um, the current administration is not pursuing that rule that had been challenged. There has been some indication that they may be looking at limiting a non-compete as it relates to medical professionals, but that is, um, again, a very, very early indication. It is not something that um, is anywhere close to happening. Um, a lot of states are moving toward this on their own. So they're doing something about non-competes. There are states that don't allow non-competes at all. There are other states that are restricting non-competes as they relate to healthcare providers. There are some that are just limiting them. So you really want to know what your state allows. Um, they certainly are something that we're seeing still happening. I will say this, don't just assume, like if you see one in your contract, don't just assume, well, this must mean that the state that I'm in allows them. You would be surprised at how often that is not the case, especially with states that have recently changed. In California and Massachusetts, states that have not had non-competes for a long time, you typically don't see them. In states that have had laws recently change, it's possible that you still will. So make sure that you're familiar with the issue. So these are the sections you're typically going to see. Which of those are the most likely to cause issues? Of course, compensation. The other is risk. as it relates to your exit strategy. So there were a few things there that we talked about that are really relevant to how you get out of the contract. And then, of course, the duties. What does your contract mean? What does it contract you to do? What does it obligate you to do? So we're going to talk through these sections. The first, of course, is assessing your compensation. And we have Dr. Jones here who signed a contract for $250,000. He is happy with this. He gets his first paycheck in his second year. It is a lot lower. He has no idea why, and he doesn't really know, kind of what's going on here. So, um, he should have understood his contracted compensation. He likely relied on what he had heard, what he had been told. He didn't know the structure. He probably didn't ask the right questions. So we're first going to talk about compensation structure. What is your pay going to be based on? How is it going to be set up? So as I've said, I've reviewed about 2,000 contracts, a little bit more than that. The overwhelming majority have fallen into one of these four categories. Sometimes they're hybrid, sometimes they're a little bit maybe more convoluted, but almost always you can put them in one of these. So the first is going to be a guarantee, flat rate, not dependent upon any metrics. This is usually only going to be offered for a certain period of time as you get your practice up and running. Where that may not be the case is in maybe in a capitated model, maybe at an FQHC, or some other situation like that. Even then, it's fairly rare and it's typically going to be limited to a time frame. A guarantee plus production would be usually what that transitions to. And that will be where you have that flat salary with the opportunity to earn more. And that would be based on increased productivity. Now, productivity can be measured in a number of different ways. You can look at panel size, patient encounters, collections, WRVUs. We see all of those. And what is used to track productivity is typically going to be based on what practice type you're in. So panel size and patient encounters, again, are going to be capitated settings, FQHCs, encounters may be urgent care, places like that. Probably not, though. And we'll get to what we would typically see there. Collections are going to be private practices, and WRVUs will be hospitals, academics, larger health systems. That's what's going to be used there. WRVUs it stands for Work Relative Value Unit, and that is the numeric value assigned to CPT codes. So every patient encounter is billed with the CPT code. Excuse me. That CPT code is given a numeric value, and those are your RVUs. So that is how, again, hospitals often track your productivity. So when we see a model that is a guarantee plus production, you're typically going to have three numbers. So you would have a guarantee. So let's say it would be a $200,000 guarantee. And then it would say, once you generate more than 4,000 RVUs, so that would be your threshold, you will be paid $50 for each RVU in excess. So you would have the $200,000 base compensation, the 4,000 RVU threshold, and the $50 conversion factor. That's the terminology given to those numbers. And so in theory, with most contracts, any of those numbers are negotiable, and you want to make sure that they all make sense. If you have a really, really, really high, fantastic conversion factor, but your threshold is insanely high and it's super unlikely that you'll ever hit it, then the conversion factor is really pretty irrelevant. Um, Now, by the same token, um, if you have an insanely high threshold that you're never going to hit and a really, really low conversion factor, I wouldn't probably spend my first negotiating, um, I wouldn't spend my initial time negotiating the conversion factor. I'd try to get the threshold down. So you want to make sure that all of that makes sense. Now, in collections, you're going to have those same numbers or three numbers. You'll have the base. The threshold will be, let's say in this case, it's $400,000. I mean, the base will be $200,000. The threshold would be $400,000. So when your collections hit 400,000, you'll make 25% of your collections in excess. So that would be your percentage. And again, you could, in theory, if they're willing, negotiate all of those numbers. Production only is in some ways the most straightforward. It is what we would typically call an eat what you kill model. It is the production only. So there's no threshold. It's just, hey, you get 25% of collections or you get $50 per RVU, right? That's all it is. There's no guarantee. There's no floor, so to speak. There is certainly more risk in this type of model. Now, there may also be more reward. When there's not a floor, there's also usually not a ceiling. So if you want to earn more, you can. The fourth one here is a time-based structure. And what that is going to look like is a situation where it's usually hospital-based. It is going to be based on the hour, based on the shift. If you're working as a pediatric hospitalist, pediatric emergency medicine, urgent care, something like that, that's typically how you would be paid. Now, you may have a contract that transitions. So you may start as a guarantee and go to a guarantee plus production, or start as a guarantee and go to production only. You may also be paid differently for different work. So you may have a hybrid position and you may be clinic, 0.75 in the clinic and 0.25 Peds hospitalist. And so you're paid guarantee plus production for one and time-based for the other. So make sure you thoroughly understand the structure. Don't kind of read the first sentence and go, okay, I get it and move on, because there can definitely be some nuance. So this is clinic-based or clinical compensation based on that work that you're doing. These are additional considerations. Are there additional roles? Are you doing research? Are you doing admin? Are there quality bonuses that you can be earning? So, of course, there are more ways to earn money than just your clinical work. The clinical work is, for most folks, obviously going to be the biggest part of it, but there can certainly be additional factors here. You also want to know, where you're working, what type of practice it is. All of those things matter as well. So you want to take all of that into consideration when determining, what you're being paid and frankly, what you should ask for. So we've taken a look at, okay, these are what the numbers are. This is what the structure is. Now what do we do? So often employers are looking to these large data reports to kind of set their numbers. And one of the largest that we see is the Medical Group Management Association report, and that is the MGMA. You'll hear that from time to time. It is a really, really useful tool. It is good to understand it. It is not the end all be all. I don't think it is prescriptive, but again, it can be valuable. So these are just a few things that I think are important to understand about that data, and a few things that I think are important um, for you. I don't want to say to be able to argue, but for you to have a good handle on. So the single piece, the single number that you will hear most often quoted is going to be total compensation. And that means all cash compensation paid to the doctor. And so the MGMA will take all of this data, we'll aggregate all of it and say for um, pediatricians in the southern region, this is the median total compensation. And that's going to include that base salary if there are any productivity bonuses, if there are any quality bonuses, if there's any call pay, anything like that. It does not include the valuation of benefits. This is important because often employers will include the valuation of benefits. So you may get a worksheet from them that at the bottom will say their total compensation package is $330,000. And then you start breaking it down and you realize that they have a line item for their retirement benefits contribution. That's a great benefit and it's really has significant value. It is not included here. So just something to remember. If they're telling you, yeah, look, we're at the MGMA, and part of how they're getting there is by including those benefits, then they're not quite there. Now, there are additional data points. All of those kind of points that we talked about earlier, the RVU threshold, the conversion factor, collections, patient encounters, everything that is going to be relevant to measuring your compensation is likely going to be in the MGMA data. So understand, if they're telling you, hey, you're going to be based on patient encounter, there is a median compensation or a median patient encounter number. I was working with a physician the other day, and she was going to be paid based on that, and her threshold was about twice the median. Okay, well, that was really good to know. And so that gave us a long list of questions to ask. So understand, um, you know, how your contract compares. The data, of course, can be filtered, and I've already sort of alluded to this. You can, look at practice type. You can look at who owns the practice. Is it a single specialty clinic, a multi-specialty clinic? What type of experience do you, the doctor, have? All of this can be really useful and really helpful. The data or the filter that is most commonly put on the data by the employer is the geographic filter. So looking at the regions, the MGMA puts the country in 4 regions. And so that's typically what I use. Employers are prohibited from cherry picking, meaning they can't say, okay, we really want this pediatrician. We really want to pay her about this much money. So let's put all of these filters on this data to get here. And then we're going to hire an OB and we want to pay them about here. So let's find the filters we need to get them here. They can't do that. They sort of have to just broadly apply the same filters. So it's good to know for you, hey, what all these, if I apply my specific filters, what are my numbers? But understand that if you take all of that to them, they may not be able to use it in that way. Now, with any data, um, there are some assumptions being made. The biggest one, in my opinion, is that the data is based on assumptions that everybody is defining full-time the same way and that every position looks the same. And I can tell you from experience that it's not. Um, I once worked for a health system in a um, smaller part of a more rural state. and uh, we were hiring a pediatrician, and we were paying at the MGMA median, and it was a very traditional practice. It was clinic based, um, nursery rounds, taking call. That's what it. That's what we were offering. Um, a couple hours away, within the same state, a children's hospital was being built. They were also offering the median, and they had two types of positions. One was clinic based, strictly clinic, no call, no nursery. The other was a peds hospitalist, no clinic work. The money was the same. On paper, you would say there were three pediatrician positions, all within the same state, all being paid the same amount of money. The positions were not the same. The amount of work was not the same. So that, in my opinion, is where the data is limited. So it's important to keep that in mind. It doesn't know the specifics. So understand that. Just understand, that it can't tell the story of what it can't tell your story, and it can't tell the story of the job that you're looking at. So here are some examples of those numbers because I think it's helpful to see them. So this is pediatric total compensation national data over the last 4 years. We will get the 2025 data in a couple of months. They're kind of putting that report together now. So you can see sort of steady increase. That's fairly typical. I was actually asked today by a doctor, like, well, you've never seen these numbers go down, right? Not just in peds, just in general. I actually have. It's not something that happens a lot, but it is something that happens. So you, I really apologize. So it's certainly something that you want to, certainly something that you want to understand. You want to know, that it can. Typically, that's only going to happen when you've had a significant spike and then it's kind of leveling back, or it's going to be a really minor decrease, but it can happen. Um, I think that this is a really, really interesting slide to look at. So this is compensation based on years in practice. And part of the reason I think it's interesting is that 8 to 12 years kind of has that high point and then it goes back down. And I don't really have an explanation for that. But I I think it's kind of an interesting anomaly. Sometimes we'll see um, compensation that it kind of peaks in the middle and it starts to go down, which sort of makes sense. You think a doctor may kind of be slowing down, but this one's a little bit more interesting than that. Um, this is beginning salary for post-residency. So this is actually guaranteed comp, which is right at 200,000 with a $10,000 relocation stipend or bonus and a $20,000 signing bonus. Again, these are not prescriptive numbers. I'm not telling you this is where you have to be, but just as an example of, hey, this is where the numbers currently are. This is some of the information that the data can provide. This is also interesting, I think. It is pediatric specialty total compensation. Um, Again, I think, really interesting. Obviously, really interesting to see where, there is clearly the highest there. Um, Interesting numbers. Again, not something that I think is prescriptive or something to say like this is, what future plans should be based on, but um, good information to have. So after all of this, the things that I get a lot are just, hey, should I ask for more money? And I think that there are a lot better questions. So, questions can be, that we see here are really getting to the heart of the compensation structure, understanding how long your guarantee is, understanding more about the quality metrics, understanding how frequently the structure is assessed and if it is applied evenly, understanding if there's call compensation. Um, if you are supervising people, is that paid? When are bonuses paid out? Do you get increased compensation over a period of years? So, can you accept a little bit less now, knowing that more is coming at some point down the road? That is sometimes, um, what I've seen doctors choose to do. And then knowing if recruitment incentives are available. Can you get additional, maybe the thought is, hey, I'm planning this contract a year and a half out. The compensation looks good. I really actually just need some support now. Can I get a monthly stipend or something along those lines? Understanding what would actually be the most useful thing for you. So, um, obviously, compensation is where we have spent most of our time tonight, but we're going to talk through the other sections as well. So, understanding your risks as it specifically relates to exit strategy. So Dr. Singh is employed where she trained. A few years later, she's ready to move on. She's not entirely sure what to do. So she should have understood termination, tail coverage, and non-compete when she got started. I think the best time to negotiate those is when you start. You don't want to wait until the end. And I know that that seems really counterintuitive and frankly, maybe a little bit awkward, but I truly do believe you're going to have better opportunities um, when nobody has heightened emotions. So when you're looking at termination, you want to understand without cause and for cause. So, for cause is a really serious situation. There's typically going to be a lot of potential implications there. What I look for in a for cause termination section is making sure we understand what they mean. And I know that that sounds overly simplistic, but whenever we see vague language, like they can terminate for cause if you don't meet their expectations, we don't really know what that means. And more importantly, we don't know how to avoid it. I want things like if you lose your license, if you're convicted of a felony. I obviously don't want those things, but if those are the things that we're talking about, we know exactly what those things mean. And that means we know how to avoid them. So that is my best advice there. If you find yourself in a situation on either side of that, then I would say contact an attorney. And that is after you're in the contract. Now, looking at a without cause termination, this just means you're ready to move on, right? Nobody's done anything wrong. What you want to look for there is a notice period, typically 90 days, and you want it to be mutual. So I've seen situations where you're going to give them 180 days and they want to give you 10 days. That's problematic, obviously. So we want everybody to be giving the same, and we want the time frame to be reasonable. So the other issues around termination. So after we've dealt with how do we get out of it, again, tail coverage. You want to be sure you know who's paying for that. Ideally, it's them. That's our best case scenario. If they're not going to cover it, then let's get it before we leave that job. So down the road, let's kind of understand what that cost may be. And maybe we can negotiate that in the next contract, right? So Okay, that's going to cost $30,000. Well, when we're negotiating the next one, let's see if the new employer will um, either pay for it or provide a $30,000 bonus that would pay. Um, we've talked some about non-competes. I will tell you my best trick for a non-compete, and that is that I have not seen a tremendous amount of luck in just getting a non-compete thrown out. Just please take this out. I don't want it in here. Employers typically are not quick to do that. Where I've seen the most luck is in carving out specific exceptions, particularly around practice type. So if you can say, look, I'm going to be in a clinic for you, and if I left here, I would go work at an FQHC, or I would go work in um, an academic institution, or I would go work in a pediatric urgent care. Um, or maybe I would go work as a hospitalist, or maybe you're currently working as a hospitalist and you would go work in a clinic-based setting. Anytime that we can look at this and say, hey, this is what I would do, and this is why it's different, that's, in my opinion, going to be a really compelling argument. I have seen doctors have success with that. And when you are in primary care or in any setting, we're seeing this more and more with OB, with GI, even to some degree with surgery, when there or neurology is another one, when there are hospitalist positions, that gives you a really great opportunity. Now, you may be in a situation or in a location where there are not pediatric hospitalists, but if you are, that is my suggestion. And then you also want to understand any um, repayment or financial penalties. So, do you have to repay a signing bonus? Do you have to pay um, back any student loan support? Are you paying any credentialing costs? Sometimes, if you terminate within a certain time frame, they want you to repay all of their expenses. So, understand what that's going to look like. Obviously, we want to negotiate that on the front end. Um, Most of the time, those are going to have, obligations. If you get a signing bonus, you're going to have to stick around for a while. Um, I would say we want to prorate that. So if it's 2 years, instead of saying if you leave during 2 years, you're going to repay it all, let's break that into 24-month chunks. So if you leave at 13 months, you pay back 11 months worth. Um, you get credit for the time that you've been there. I've seen some that look at pay period, or even some that look at the day, right? So we're going to total up the number of days and you get credit for each day you've worked. As granular as they're willing to go, I would do it. You can also look at why the contract ended, meaning if they terminate you, you won't have to pay this back. We, of course, want to talk through, and we'll be cognizant of time here. I appreciate y'all um, your time. And I also want to just note that at the end of our webinar tonight, there will be a promo code that you can use for our services. So if you can stick around, certainly try to do so. But we're going to talk about the expectations. So Dr. Wen joined a group of 4. They all had Fridays off. She's excited and then gets her schedule, and she's working Friday but has Wednesday off. She made some assumptions about the schedule. She didn't understand the specifics. She likely didn't ask questions. She didn't get specific information. So, what should she have done? These are the areas, in my opinion, you should ask about. I do not expect volume to be addressed in your contract unless volume is being used to measure your productivity in a way that will trigger a bonus. Um, but you want to understand your schedule. You want to understand what you're expected to work and how you can work that. Meaning, is it measured in hours, shifts, clinic sessions? How can you break that up? Does that have to be done, assuming it's 40 hours, can that be done in 4 10s? Does it have to be over 5 days? Are there any weekend expectations, any early or late shifts? And then we'll look at call as well. What call is expected? Is that clinic call? Is that any ER call as well? Typically, it's not, but you never know. If we say call is equal or equitable, understand that that means if half the group leaves, your call goes up. So that's not a hard cap. Um, I also often see, hey, if call goes in excess of X, then you're going to have to, then you're going to get paid essentially. We also want to understand location. And I know that you may have seen the job posting for this one location. You may have visited and toured one location, but your contract may say you'll work wherever we tell you. I would love for the contract to say your location will be based on mutual agreement, meaning they can't just send you somewhere. You're going to have to say, yeah, that works for me. Um, or they can just specify this is your primary location. But the mutual agreement does give you some flexibility. So I think that would be a positive thing. So these are great questions to ask about their expectations, about what they see as a successful kind of growth in the position, what they want for um, the clinic, what they want for the rest of the staff. I will quickly, I know we're really short on time, but I will quickly say, you look at support staff and um, what the turnover is like. I worked previously for a health system with a pediatrician who was beloved. She was phenomenal. Um, Everyone, doctors, administrators, patient, I mean, everybody loved her. She never got her full quality bonus because the quality bonus was based on patient satisfaction. And many of the questions in the patient satisfaction survey were based on clinic staff, wait times in the clinic, friendliness of the people welcoming you, and her clinic had a lot of turnover. And so people would get called and the questions specifically about her, they would rate incredibly high. But the questions about the clinic staff and the actual clinic would rate low, but they all counted towards her. So you may look at the question about staffing and think, well, why do I care about that? Well, it can matter a lot more than you think it can matter. So understanding, does this clinic have what they need in all aspects? Those can be really important conversations. So we'll finish off here with a minute left at red flags. The biggest red flag that I see is a lack of transparency. When they are unwilling to talk to you about any of these questions, when they won't share information, when they won't address your concerns, when there are things they are telling you are going to happen or you'll have that are not specified in the contract, um, that's a big red flag. Part of that is also when you're taking on all the risk. You've got a huge non-compete, you're paying malpractice, you've got financial penalties, you've got the longer notice period, all of that, and they're just not willing to give on anything like that. Even if they're not going to make changes to the contract, if they're willing to answer questions to sort of open up um, their policies, their information to you and really talk through things, then I think that's really positive. So just something here to to think through. Again, I know it would be easier if I had like, a list of like, these are the phrases that if you see these run. Unfortunately, I don't. Red flags are really going to be different for every person because every person has different goals and is looking for different things. Um, but it's really more about sort of the attitude and the approach that they have. So we've talked about compensation structure. We've talked about how to set yourself up for the end of the contract and how to have a smooth exit, and about how to measure success during the term. I really appreciate your time tonight. It has been great to get to talk through this with you. There is a promo code here on our screen. It's PEDS Comp 20, and you can enter it when you sign up for our services and you'll get 20% off. My email address and our website is here. Also in the chat, there is a link where you can sign up for a free 15-minute consultation, which uh, we would love for you to do. If you have more specific questions, if you have questions that I can answer now, you can put those in the chat or in the Q&A box, and I'm happy to answer those here.